Aileen and Lynn, there's some new things that are coming to the center that were not necessarily anticipated. I'm sure many of you have seen some of the news articles out there with regards to Auburn City Ambulance. The city has decided to stop the contract with TLC, and they are going to have their own ambulance service in-house. So what that means for us is it's a new agency to dispatch. What that also means is any of the transport calls that generally we had no involvement in will start coming to the center. So these calls are things like Northbrook Heights has a patient they need transported to ACH, or ACH has a patient that they need sent to upstate. Any of those calls that happened in the past generally went right to either TLC or directly to TLC. So we had no involvement in those calls. We essentially had no knowledge of those calls. They would contract with the ambulance service, and it would go right to the transport would happen, kind of behind the scenes. So at this point now, those calls are all going to come into the center. We'll generate a complaint for that, and we'll track the ambulance. So it's definitely going to impact our staffing and our operations. I was already asking for a new position because of the workload, and that's partially because we are never fully staffed. In the past 15 years, I think for a total of a year, and that's broken up, 6 months here, 3 months here, a couple months here, we've been fully staffed. It's very, very difficult for us to maintain staffing levels. 15 years ago, we saw a list of 100. This day and age, I get a list of maybe 13 or 16 people. We are just not seeing people taking the tests, and even a list of 16 doesn't mean it's 16 qualified candidates. It's maybe 6 or 7 if we're lucky. So, I explained in the budget that, I'm asking for more positions. That doesn't mean it's going to have a significant impact on my budget at the end of the day. I did some trends over the last 4 years, and, generally we are over budget in overtime. We are always under budget in our salary line. So, they offset one another. But kind of the hidden message there is that we're burning out our good staff. They are constantly working overtime, to fill vacancies and fill vacations and fill sick leaves. I've got 2 people who were just out on sick leave for extended periods. Plus we had a resignation. So, hey, we're still too short right now. And then taking on Auburn City Ambulance is really going to have an impact on us. So, just kind of looking at my budget, those 2 positions, they'll have an initial impact at the bottom line, but I think at the end of the year, we'll see, because we are never fully staffed, you won't see a huge impact at the end of the day. Even filling them, I won't have a list until probably April. There's a test coming out in January. So civil service is not super fast at the state level. I expect the list to come out probably April, hire maybe June by the time we interview, go through the background process. Then they have to go through a long training degree. It'll be the end of 2022 before we have staff that's trained. So, that's kind of one of the other reasons why we need to improve our staffing, because when we do lose somebody, it's a good year before we're ever filling that position with somebody who's qualified and trained. Any questions on that before I move on to the next thing? I feel like I just said a lot.
Yeah, you did say a lot, but
Yeah, I feel like that was a lot.
So I understand from what you've said that one of the staffing pressures for us is going to be that the new contract that the city of Auburn or the contract they canceled, the new approach they're making with the ambulance service means that calls that did not used to come through 911, which are basically just non-emergency transport, those are all going to come through 911 now. Is that has anyone explored with Auburn and taking those calls directly as has been done in the past? Because
So,
if the problem is going to be, I think, from what you said, is that if the call volume increases with non-emergency calls and we can't staff up quickly enough, then something's got to give. and the, and I don't know what that's gonna be, but you can't, if a call comes in, you gotta take it. And if it's non-emergency, I don't know, you see what I'm getting at. I mean, how are we
Yeah,
gonna
I
deal with that?
understand what you're saying. I don't know that there is the potential for them to take them themselves, because essentially, if they take that call, they're still passing it to us to dispatch. So you're kind of slowing down the process, if that makes sense, because we're taking the
No,
call.
it doesn't. If they're taking over the service, why can't the service, the, whatchamacallit, I don't even know, I don't remember, I don't live in Auburn, I'm embarrassed to say, I lose track of what Auburn and whatever the service was called. If they took the calls when they're non-emergency, there's no reason that whoever's operating the city of Auburn ambulance couldn't take the calls if it's not emergency.
Well, that's something that I would say Amy can have a discussion with
Okay,
Jeff,
so there's
but
been, no, that wasn't considered when they looked at the ambulance.
that was
transfer.
not. So
Okay.
I will tell you one
I
thing.
guess, sorry, that was my question.
That's okay.
and
I
I
will
was
tell you.
very confused about it.
Yeah.
Forgive me for being so
So
difficult.
the
with
one
that
question
word.
I did pose was, would the city be willing to fund a position?
Fund the county position?
Correct, to support the dispatch.
The better solution would
Yeah.
be, because if we have trouble getting people,
So,
the better solution would be to figure out a way that they could take the calls, frankly, right? Because in any event, I just wanted to be clear on what the issue was, and now I know. And I'm sorry I didn't ask a question that was direct enough so you can answer.
Yeah, that's okay. And they think the call volume is going to be somewhere between 11 and 1,300 calls. But the problem is we don't know that. We have no idea.
Right.
Because we're passing on from a private company who, they don't post their numbers.
or may not want to.
Correct.
Okay, thank you. Thanks, yeah.
And then,
Elaine.
Denise, didn't we not have some Auburn firefighters that were at night at the center working at one time?
We did have some part-time dispatchers that were Auburn firefighters. They are no longer part-time dispatchers. One of them is retired from Auburn Fire as well.
Did that help?
Part-time dispatchers help, but not, because they pick and choose when they want to work. We need to know that we have staff in those seats. So that's the important part of full-time staff, is that we schedule them and we know what they're there. We don't do that with part-time staff. We can't schedule them.
So the non-emergency calls are gonna be the most problematic, because you always did emergency calls. Is that your?
So emergency calls have always come into the center. And what happens is dispatch would pick up the phone, call TLC, give them the information, hang up the phone.
Okay.
Emergency calls are now just gonna be dispatched directly to the ambulances. So that's not gonna be a huge undertaking. The undertaking is gonna be those transport calls, the additional.
The non-emergency transport
Yep.
calls, the ones Keith was saying,
Yes,
the conversation could be, can they manage those themselves?
this is starting November 1st.
Yep.
As an FYI.
And back to if you're successful getting the additional staff, then you'll make adjustments in the overtime amount lines.
That's obviously our goal.
And if you're assuming that they wouldn't be available to start till 4 months into the year, you could budget that accordingly.
Yeah,
as well.
we would not be hiring anytime before May. That would just not happen.
And you haven't spoke with Auburn about the non-emergency, that you're thinking maybe you may be doing some.
I've been in a couple of meetings with them, absolutely, but I don't know that I can tell that we're not gonna do it.
No,
I
I
don't know
get
that they're
that,
comfortable
yep,
doing that.
okay.
Did you attempt in any way to contact TLC or whatever to see how many non-emergency calls they get in a month or a year?
So I did try to get some numbers, but I don't have the numbers.
Any other questions for Denise?
The only thing I have left, I was actually hoping Legislator Strong would be here. We've been getting a lot of complaints from the southern end regarding the radio system. And they feel that they've seen some system degradation since we implemented the system. Motorola went out and did a lot of testing over the course of the last week in the areas that were highlighted as problematic areas. the majority of the areas they found to be okay. There definitely are some weaker areas and poor coverage areas. They align with the coverage maps from, the start of the system. I tried to explain to the individuals that are, experiencing the issues that, these are not new. Unfortunately, we don't build systems for 100% coverage. Ours is 97% mobile coverage, and we've always had great, we really had great coverage. The weaker areas, yeah, there are dead spots in the system. I think if you ask across the state, it's part of, the nature of the beast. I do have a meeting with Motorola on Thursday to go over some things, and this is one of the talking points. I don't know that a new tower site will resolve it because there are kind of spotty areas throughout, and a tower site's not going to cover all of the areas. So, just as an FYI, I'm sure it's going to come up at some point that we're trying to look at some different ideas, but aside from spending a lot of money, I don't know that we're going to be able to resolve it. Yes, sir.
If you were to build state-of-the-art network today, would it be Motorola or, is the microwave system we have now or technology that we have now, is it gone one step farther?
I think technology changes from day to day. So I think that's, but we do consistent upgrades to the system. We've been upgrading our microwave network. So we have a pretty robust system.
But is microwave,
Microwave is the technology you're going to use, yes.
They both pooped. They're so funny. They both went out. Oh, because I'm confused. They both went out and pooped before.
Portable technologies that, work on the first network that we're going to look at, but it's costly. You're talking $14,000 portable.
Any other questions? Peggy?
Just one quick
You
back
barely
question.
got in there.
If you had, Denise, if you had like your dream budget, is there a way to cover those dead spots? Or
It would
Could be dead
require
spots.
probably some new tower sites.
when you say some, how many?
Probably a minimum of 2. You're talking, $1 million.
Nothing.
Just gives a good picture. Thank you.
Anybody else? Is there anybody on? Otherwise, we'll.
We'll go out and clean up your poopy. You want to come out? You might clean up some poopy. Come on, Mel. If you want to come. Behave yourself, Harley. Calm down.
Thank
Thank you, Denise. We'll move right along. Is Lloyd Hoskins on the call or? My intended report.
Lloyd, are you on? I
No,
don't,
Dale is on, so Dale wants to,
I don't see Lloyd on.
right. Dale, are you there?
I am here,
All right.
smiling. Am I on?
Yes, you are.
Okay. Well, good evening, everyone. Thank you for your time. I will attempt to be brief and just provide you some updates on what was submitted in our report. The first item, the highest priority of EMS services. If you note on the middle lines there, there's a number of factors impacting EMS services. The increased frequency and duration of hospital ER diversions is getting more prevalent, more problematic, as well as not only the frequency, but the quantity. They're an everyday occurrence to the point where the state actually came out with policy maybe last week dealing with how our EMS agencies supposed to function when all 4 Syracuse hospitals go on diversion at the same time. Keeping in mind, some of these diversions aren't just 1 or 2 hours like they used to be. They may be 10, 12, 14 hours. So that's getting to be a bigger challenge. There's numerous groups working on this, but more and more, this is as much a problem as ongoing staffing. In the planning section, I'm going to connect the dots for planning and recovery, because at this point, they definitely go together. We are working with the municipalities who participated in the hazard mitigation plan revision in order to get their resolutions from their governing bodies. We have to turn that into New York State, and then that goes to FEMA to finalize this process. We have gotten, I think, maybe 5 or 6 in the last couple of weeks. It's taking continued reminders and updates and nudging, if you will, because the importance is great, particularly for some communities right now. Now that we got the FEMA resolution, presidential disaster resolution, there will be money forthcoming for public assistance, government-owned properties, et cetera. And so there are some towns, municipalities involved. And one of the questions that comes up initially in the paperwork is, does your community have an approved, accepted hazard mitigation plan? We've had to explain that to at least one community to nudge them to not keep putting this resolution off. So I would ask, if you have concerns about the communities you represent, please reach out to their officials and make sure they get these resolutions in front of their governing boards for acceptance. We made it pretty easy. We sent them a template. Basically, they only had to fill in about 4 lines, add a couple of dates and a signature. So it's not a big lift. So any help you can provide would be greatly appreciated. And on the operations end, we did hold a after action review conference back early September. We had about 15 people attended from the state. We did have a rep from Upstate Medical, Onondaga County, one from Seneca County, and a number of Cayuga County agencies to do a walkthrough of the response to the thruway bus crash. There were a number of lessons learned. Overall, it went very, very, very well. The weather couldn't have been better. Timing and availability of resources was really great. So, but there are always some lessons learned. So we're working on a improvement plan and continuing to work on that so we can integrate it with what we're working on to upgrade our mass casualty and mass fatality plans. And the last item, just a quick update on the training. We do have more and more fire training classes being offered. We've had a couple that didn't go because of lack of meeting the minimum number of people required by the state. And a couple of them have just squeaked by, but we're again reaching out repeatedly to get people to take advantage of these, because the last year and a half or so, they've not been readily available. So with that, I will ask, is there anything I can add or clarify? There is one other item under recovery. Somebody's probably waiting to ask the question, what about individual assistance for homeowners? That was not included in the declaration, nor was SBA loans for businesses. I do know the governor did request both of those, and I've not heard whether the state is going to appeal the declaration and see if they can get more money. I did notice in Senator Schumer's website that he noted that he was gonna go looking for more money, which appeared to fall under the individual assistance for Steuben County, but he did not list the other 6. And Steuben certainly took the hardest hit, particularly on privately owned homes and such. So I wouldn't bet lunch at a hot dog cart right now that will have individual assistance available to us. But if we hear any more, we'll certainly let you know immediately. So I'm done.
Thank you, Dale. Before I get into other questions, I don't really want to go into a discussion about this right now, but, you know, I've been, over the last year, 5 years or so, we continue to hear how the towns are having more and more trouble manning their volunteer fire departments, their ambulance services and things like that. And sometimes people look to us as to how, you know, we gotta resolve this problem. And speaking for myself, I would like, I'm not saying it's not a real problem, but it would be really nice if the towns and their fire departments and things would get together and really comprehensively look at it and give, and it might not be just the county, it might be the state. I mean, is this a problem with each and every county? Then it's not a county issue, it's a state problem.
It's a
Yeah.
it's a national problem, and it's been a national problem and a problem across the state for easily 10 years. It's just getting much worse quicker.
What I'm saying, Dale, is it would really, really nice if these towns and things could get together and propose some resolutions, some alternatives, because, you know, as a legislator or an assemblyman from the state or somebody from the federal government, they don't know what goes on the ground. They have no clue what happens day to day. And it would be really nice if the people that are doing it day to day would be able to put forth some alternatives or some solutions. Wait for the people sitting in these chairs, it's gonna be a long, long time.
Yeah,
I don't
well,
know.
if I can just make 2 quick statements. One is fire and EMS are 2 very different entities. State law mandates that municipalities provide some form or level of fire protection, and that is typically done contractually with their local fire departments. So key object here is money. Their response and stuff could be better if they had the money to pay people, because volunteerism in any organization right now, or what was typically volunteer for decades, people just don't volunteer, particularly for dangerous stuff. Contrasting EMS, there is no, whereas fire is statutorily listed as an essential service, EMS is not. And therefore, there are many, many factors involved in this, but again, it comes down to money. It's $500,000 a year for one ambulance and staff to keep it staffed 24/7. And municipalities, they don't, since they're not statutorily required to provide it, they don't want to pay for it.
I have another question from Keith Batman.
Yeah, my question is there's something you can do. If the hazard mitigation plans for the towns are a problem and a number of towns don't have them, can you send us the list of towns that have not submitted a hazard mitigation plan? And I'm sure everyone in the legislature that represents those towns will reach out.
There is only one, and I want to say it's the town of Ira. And we've talked to them many, many, many times. They have recently come back to us and said, oops, we should have done this. So we have put them in contact with our consultant firm to work with them on their own dime at this point in time to get a plan to be part of the county plan. We managed to get everybody else on board.
So it's not a problem, except in the town of Ira?
Yeah.
Well, it's still, the ones who are part of the plan, they still have to adopt them.
But that's,
Um,
Dale, that's my question. There's nothing we can do to reach out to the towns unless we know which towns we need to reach out to. I mean, I don't want to send a general email to all the towns that I represent saying, get this done, if they've
Right.
already.
Sure, it'll be easier. I can, when I go in tomorrow, because I know we had a couple today, Victory and another one, Victory, Moravia, they have signed on. It'll be easier. We'll send out the list. I think there's 5 that have done resolutions. The rest have not yet.
But yeah, and I'm sure we will all follow up on that because it is important.
Thank you.
Thanks.
Any other questions for Dale? Tim?
Now, we have been declared a disaster area, right? Is that what,
Well, we met the threshold.
so we don't know what.
We met the threshold for public assistance. Yes.
We don't know what the result of that's gonna be.
2-to-1 match or,
We don't know.
okay.
Oh, no, we know. FEMA pays 75%. The locals have to pay 25%. And that, some of that can be in-kind services.
Thank you.
Okay, thank you, Dale. Any other questions? Right, let's move right along. Dr. Duckett is not on, I don't think. I know he has.
I'm
resolution.
I'm on. Oh, I'm actually on. I'm sorry. I couldn't unmute you.
Is there
So,
any other updates other than the resolution?
I think it's kind of related. I did want to piggyback a couple things. I guess it's unrelated to coroners per se. But when Denise was talking about some of the issues with Northbrook Heights and non-emergency transfers, one thing that we're trying to work with the medical center, the ESO Medical Center, since we are the primary care providers for many individuals there, is trying to prevent those types of calls and transfers needing to happen, trying to do more with video visits and at the time kind of treatment assessments to see if the patient sometimes needs to actually go anywhere. But I'm not familiar if they're doing other things beyond that, but we're trying our best to try to keep people there. A lot of their policy and procedures necessitate them to be evaluated even for non-emergent matters. So it gets a bit complicated. So Denise, if there's anything you wanted to loop in with that and anything we can be an assistance of, we certainly would love to help you guys on that. So.
All right, I know you have a resolution.
Yes,
Dr. Duckett,
yes.
I'm gonna,
So,
move
So-
on to the resolution at the end, if you don't mind.
okay, sure. No, that's not a problem. I will say, just as a precursor, this has been a very, very busy season for the coroner's office and some very, very bizarre things that we've had to encounter and some very challenging things. So that's kind of related to why we are with our resolution. So we'll talk about it at the end. So thank you.
The DA's office.
You mind if I speak?
Yes, oh,
Okay.
that's good.
Great, thank you. Hi, everyone, good afternoon. Just very briefly, our aid to prosecution grant numbers we're doing well. We're finally back on track with our pre-COVID numbers with respect to our felony cases. The only thing we're still a little behind on are our number of days it takes for us to dispose of a felony case. We're right around 6 months. Pre-COVID, we were around 5 months, so we're getting there. We did about 12 days better, 12 days quicker than we did last quarter. So we're finally getting caught up with our backlog that COVID caused. We're sending 2 of our newer ADAs to DWI training in Albany in the next couple weeks for about 4 days, so that's great. Our New York Training Institute is actually gonna pay for them to stay overnight and go to that training. It's a wonderful training. I went to it a couple of years back, so I'm excited for them. And then we do have a resolution on. We are looking to fill an attorney vacancy. Hopefully this time with someone who has experience. It'd be nice to not have to go through the full training process and then lose someone so quickly. So we are hoping to hopefully be able to fill that with a more experienced attorney this time.
Any questions for the DA other than DA's office, other than the resolution?
Mr. Chairman, I'm gonna have to leave, but I'm in support of the resolutions.
Thank you. Sheriff.
Good evening. In addition to my report, I just wanted to give an update relative to our police community collaborative plan relative to the governor's executive order 203, the plan that we submitted back in April. I've been tasked with bringing an update to this body quarterly, so it's that time again. As everybody recalls, we did make a presentation relative to body worn cameras. That was one of the items that we were supposed to bring forth in September to the legislature, so we did take care of that in August. Check that off the list. Another item was to convene stakeholders to explore expansion of the mobile crisis team for mental health. I know that the mental health director is looking at potential avenues to expand those services for not only mental health crises, but also issues related to addiction. Those that are struggling with addiction are a crisis as well. So I know that's being worked on. Another item, I was tasked with exploring community advisement group to see if we could bring citizens from our community on board to work closely with our sheriff's office. Any issue that comes to our community that could be a public safety issue, and including social justice issues, addiction, those types of things. I have been working with some community members to establish a group. I have a small number of people gathered up already. We're going to meet in November and begin to try to formulate what this will look like, the structure of it, and put a plan together to bring that forward. So that is moving forward as well. We were asked to post all of our relative law enforcement policies on our department website. We have done that. We checked that off the list, as well as clearly mark or clearly post complaint procedures on our website for anyone that would want, anyone in the community that might want to file a complaint against our sheriff's office. So that's been added to our website as well. And then the final item, we are going to be putting out a community-wide survey in the coming months. We'll be doing that yearly for our plan to try to get feedback from the community and determine if there's anything of concern. Obviously, things that we can do to do better, to try to get some feedback from the community, and as far as how we're doing out there providing law enforcement services. That will be going out in the next few months, and then we'll be taking a look at that data along with our annual meeting with the legislature, which is slated to be scheduled by the chair in March. So we are on top of all of those items and checking those off of our list. So they're going as planned. Other than that, I don't have anything additional. Yeah, I'm reported, but happy to answer any questions.
Any questions for the sheriff?
I'm sorry, the enhancement of the mobile crisis, this is the midnight to 7 sort of expansion that was looked at possibly through limited resources, or you working with Ray, or?
I know that Ray is looking at that. I'm not sure where he's at as far as actual expansion beyond midnight, but I know that he is looking to expand those services to assist in overdose cases and issues where addiction is a primary factor, as well as mental health. But I think he will have to update the body on where he's at looking at that as far as being available after midnight for us.
But that was the objective, to work together if it was even possible.
Our goal in law enforcement is to try to make that available if possible,
Yes,
24 hours
okay.
a day, 7 days a week, so
Yep.
that we could provide a mental health response to a mental health incident, but a law enforcement response to a mental health incident. So we're still, I still advocate for that. I know certainly there's significant cost likely to come with that, but that's something that we would have to just.
Any other questions? Otherwise, we'll get right to the resolutions. JP one in the corner. Do I have a motion for JP one?
Move it, Nightingale.
Heidi, second. Mr. Didio, any discussion on JP one?
Yeah, I have a question.
Yes,
Keith, I understand the issue and the need and so on. I'm curious, 85,000, I think that's the amount. Unless
Yes,
I
it is.
remember wrong. That's a lot of money on what is my memory is that the base budget to cover I didn't have a chance to look it up, but my memory, what is the base budget for the autopsies?
Well, for the autopsies per case, and to be honest, right now I'm trying, as you're bringing that up, I'm trying to bring up my Excel spreadsheet from our budget. Let me break down some points. First and foremost, everything in the past year has gone up in costs for a very long time. If you recall, when we were talking about changes, Cayuga County, Onondaga Medical Examiner was when they did a cost assessment, they realized that they were under billing for a lot of their services, which resulted in them having a hard time recruiting forensic pathologists, et cetera. So they brought their kind of fees up in line with what they're doing out in Monroe and all surrounding counties, practically within, $100. So currently right now, when we take a look, every time we send a body out, they are around $4,700. When you include, $4,795 when you include the transport for the livery service. They're $4,500 for the autopsy and toxicology. They are now doing toxicologies practically on all these kind of unexplained deaths just because of how prevalent addiction is. So that's part of the cost. I also want to say that, in 2020, the Department of Corrections, when I was working with Marcia a while ago, before we were never billing for those, soon after I came into office, we realized that we've been losing money because the state's supposed to kind of reimburse. So in 2020, we had $23,975 for 5 individuals that were in the Auburn Correctional Facility. And in April of this year, because we always bill in March the following year, we got reimbursed that nearly $24,000. So we are doing what we can to do with it, but with the cost of these exams, just with the deceased that was from the car accident recently, there was 2 just there, so there's $10,000, and there was an unborn infant that also would have to come into factor too, and I'm waiting to see what that actual charge would be. So the reason why of $85,000 more is that we still have a lot of time left. We have bags and different things to get as well, which have been on order, which are pretty expensive. They can be up $100 a bag. So that's where all those expenses are for that purpose.
Okay. Yeah, and that wasn't my question.
I know it's not your question. I can't bring it up right now. I will have that emailed. I'm trying to sign on and I can't because it's not allowing me to for some reason. So if someone can, if I can send that to you, I can have Marcia send it to your email tomorrow of what our budget has been to the nickel.
We can get that number, and I am interested in that. My second question with this is do we not have a contract with Onondaga County? I thought we did.
We do have a contract with Onondaga County, yes.
Specify a price?
That's a set prices, yes, the $4,500 per autopsy.
Okay, so how could that have gone up then during the year? Because maybe I misheard. I thought I heard you.
No, I said in the past year they've had an increase in their costs, but the biggest issue is the volumes of calls that we've had. Suicides have been up. The amount of things that actually require autopsy. In this past week alone. Oh, go ahead.
Yeah, it was not clear to me.
Yeah, the amount of calls that we've been requiring, from the Wheeler Street incident, to the Lake Ave incident, to bodies, washing up on shore, people being found naked on the side of driveways, alcohol related deaths on motorcycles and in trucks. We are all up this year significantly on these cases. And so with the sheer volume of people, this has kind of blown our budget out of proportion just because so many people are requiring a full autopsy and toxicology because of the types of cases that we're getting. This is kind of unprecedented. I mean, suicides up this year, the whole 9 yards.
That answered my question, thanks.
Oh, okay.
So for me, simple math is that if an autopsy is $47.95 and the resolution is asking for $85,000 more dollars, then you're looking at 13 bodies.
So what we're looking to do is, like I said, I mean, if you had with the volume of what it is, we wanted to make sure there was enough money there for it. If it was money at the end, obviously kind of put it back in the general fund. That's not an issue. I just didn't want to have to come back and ask for more because, again, with the volumes that we've been seeing and the amount of calls that we've been having, and even in the past couple of weeks, I mean, I've been called in the past 24 hours, I've been called twice. There's times in my career with this that I could go 3 weeks without a phone call. I've gone out in the past week 3 times to 3 different calls on overnights. So it's just we wanted to make sure, especially going in when we understand that the end of summer is when we get a lot of issues with overdoses and things like that. I wanted to make sure that there was money there for that purpose and to make sure that the coverage is there. If you wanted to amend where obviously the money goes back in the general fund, I just wanted to make sure that we obviously have the money to pay for autopsies that we need to have done.
All in favor? Anyone opposed? Carried, thank you.
Thank you.
This one is JP2. Do I have a motion for JP2?
I'll move it.
Mr. Batman, do we have a second? Ms. Daly, any questions regarding JP2? All in favor?
Aye.
Anyone opposed? Carried. Thank you very much. Sure, we have. Let's see, do we want to bundle any of the sheriffs?
I think I'll move the bundle of all.
Let's bundle all of them but number 7.
Number 7.
3, 4, 5, and 6.
I move that.
Mr. Batman, do we have a second? I saw Heidi's hand go up. Do we have a discussion? All in favor on 3, 4, 5, and 6?
Aye.
Anyone opposed? Carried. JP7 was added. Sheriff, this kind of just popped up in the last day or two. And so I have a resolution for JP7.
Yeah, I'll move it.
Dr. Batman, second. Video, any discussion? All in favor?
Aye.
Anyone opposed? Carried. Any other business brought before this committee? Motion to adjourn. Mr. Video,
Thank you.
seconded to Heidi. Any discussion? All in favor?
Aye.
Carried.
Did you
Thank
do
you very
JP2?
much. Wow.
Did you do JP2?
Did I what?
Did we do JP2?
Yes.
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 Oh,
That's
okay,
the
yeah.
ADA.
Yeah, sorry.
Yeah.
Must have been sorry about that.
Okay, thank you.
Thank you.
Oh, no problem.
But that is. I was using the solution.
I like that.
That's just my thought.
Yeah. and you
Okay.
reach out
So
to
somebody.
Right,
To meet that,
right, yeah.
and then they just report it, they get a little bit of report, and the little they use, so yeah.
We like,
We are
Okay. Can we call the Health and Human Services Committee meeting to order? All right, we have a quorum, and I'm looking for approval of the September 13th minutes.
Second.
Okay, all in favor?
Aye.
All right, great. We do have quite a few appointments. We have 3 appointments to the Mental Health Subcommittee, 3 to PWDD, and 2 to the Community Services Board. I'll entertain a motion to move those appointments.
Nightingale moves.
All right, any questions or concerns?
Just one question.
Okay.
How do these names get generated? Do they come from a nominating committee or?
Yes, there is a nominating committee that's part of the Community Services Board that looks at the potential nominations and brings a recommendation forward to the Community Services Board.
Okay, thanks.
Okay, all in favor?
Aye.
And, okay, great. We do have 11 resolutions tonight. Obviously, one from Office for Aging, 4 Health Department, 4, and then there is 4 from Human Services, 1 Mental Health, and then there's 1 listed as County Attorney, which has to do with the local law. So if we want to maybe start, if Brenda's available, we can start with Brenda and have her go over HH1. Move that forward and then get on with the agenda. I don't
Hi,
know.
thanks. All
Uh,
right.
Do that you can, we can ask questions on your report, or we can do your resolution and then you can give us an update, however you want to do it.
Yeah, I'd like to start with any questions from my report. Anybody has any?
Questions for Brenda in terms of the information she's made available to us?
This is Heidi. Brenda, you talk about severe shortage of aides. Can you give us a percentage that can identify that severity in a context of, are you down 50%? How, in what way is it impact? Obviously, there's negative impact, but something that gives me a statistical mathematical point of view.
Sure. Heidi, it's always been tough for us to obtain any personal care assistance for folks in the rural areas. In the last 5 years, it's become almost impossible to even find aides to provide any type of personal care, even in the city of Auburn. And over the last approximately 9 months, we have over 60 people on our ISIP caseload, and only 2 of them were able to consistently get a personal care aide, even though the greatest majority of them actually need a personal care aide. The other folks are getting by with housekeeping only, as a means of having somebody else in the house or in the apartment when they are hopefully able to do some bathing on their own, or by providing some assistance with housekeeping. We're trying to free up the family to maybe provide the personal care assistance that we can't get aides to do. Also, to put it in perspective, I've been in the field a long time. In years ago, when an individual was open to a certified home healthcare agency under Medicare, and they came home from the hospital or came home for the nursing home, if they qualified for the skilled nursing services in the home, most of the time there would also be aid service provided. Now it's rare for somebody to get an aid. It's almost never, ever do they get an aid. It's severe. It's the worst I've seen it in at least 3 decades.
And what I'll just add to this for the committee's consideration of the full picture is that I happen to know through anecdotal experience that families are told by hospital social workers at the time of discharge of an elder who needs care and these kinds of services, that they'll qualify for these aids. They're given this full sense of confidence that these things are available to them. And one call later, when they're home with their elder, the whole plan is smashed.
Yes.
And if you
Yes.
folks and 2 of them getting services, that's, do the math there, that's a wreck.
I 100% agree. And we also get those heartbreaking calls from people who were told at discharge that somebody would be coming to the home, and they believed that an aide would be coming. And they call us trying to find out why the system is not delivering. And of course, we're the non-medical provider. So when somebody is eligible for Medicare covered services in the home following a nursing home or hospital discharge, we're not able to provide that service. That's what the certified home health agencies do. But they also have this extreme difficulty trying to find aides. One of the biggest issues is that the aides are paid. Many agencies are paying just about minimum wage, and people are able to work in any food service setting and make $3 to $5 more an hour. And the job is not driving from home to home. It's not working in the difficult situations. It's not as physically demanding. There's a lot of issues involved. There are some advocacy efforts going on right now, and for looking for fair pay and better working conditions. And but we have a ways to go. It's a major issue.
Thank you.
Yeah, I'd love to talk with you more, Heidi, anytime about it.
Thanks.
Yeah, I'll just add that the advisory, we talked a little bit about the fact that there are ISEP funds coming into the community, over $200,000 that are just going unspent because there is not the availability of aid service. And as you said, Brenda, you might be delivering 1 or 2 hours a day, and that isn't conducive to having a lot of travel, and you don't have the human resource to do it. So yeah, it's
right. And and then for the aides that are out there, all the agencies, including ourselves, we're all kind of competing for the same people. There are some efforts to raise some pay. We're trying to offer enhanced pay, but there also aren't a lot of providers that provide this level of hands-on care that we need. And those providers are going to always prioritize typically cases that are services to folks who have Medicaid. And so an aide might be able to go to a home and spend 8 to 10 to 12 hours possibly in a home. And that is reimbursable under Medicaid, where our program is very limited in the hours. Typically, somebody might get 4 to 6 hours in an entire week. And again, this is our model is a non-medical program that's meant to provide those preliminary early needs to help people stay in their own homes. But at this point, we're kind of being left in the dust because the shortage of aides is so bad that when I call agencies to ask them if they would serve our clients if we offer an enhanced pay rate, they say, no, you are not providing, your business isn't big enough for us, is really what it comes down to. Even if I offer an extra enhanced pay rate, we're kind of small, and when the resources are so slim for the aides, we can't compete. So
Right now, with Kathleen Cuddy's need for contact tracers.
and the EMS and just all of these critical care providers, nursing, it's a tough time right now. And for us, our biggest concern is our senior population is growing. So the need is just going to continue to grow. Something's got to change, something's got to give.
Any other questions for Brenda? All right, if you want to go through HH1, authorization to accept additional funds from New York State Office for the Aging. These are unmet need funds in the amount of $75,000 that we talked about at the advisory also, that you're looking to use for this work with Arise and providing ramps in the county. Is that the case?
Yes, so this was some money that New York State Office for the Aging had available. We had not gotten it delivered to Cayuga County in recent years, and I spoke with the NYSOFA director and advocated for our county to get some of this funding. And I'm very pleased to be able to bring the $75,000 in, and we are intending to use it, as I talked a little bit last time about using it to contract with Arise and also purchase a storage unit to get a base supply of aluminum ramps to provide ramps, increase the ramp availability for seniors in our county. It's been very limited. We're all using the same referrals in terms of working through Homesite or working through Arise or working through Bishop Sheen and some of the other programs that have access to home or restore funds. But we have way more requests for ramps than any of those programs can meet. So we're hoping that this helps address that need. And again, it's a very big factor for people who are returning home from rehab and are needing to be able to get in and out of their home safely. It's really important for people who are dependent on a wheelchair, who are living at home long-term, but need that kind of ability and assistance to be able to get in and out. So the funding upfront, this funding has to be spent by the end of March, or the expenses incurred by the end of March. So we have a limited time frame. This is seems like the best way to go about it. Purchasing ramps, purchasing a storage unit, placing the storage unit on county property, so that our county will have an ongoing supply of these components to create these ramps. And then the best part is that Arise is willing to work with us in terms of the installation and also looking at additional ways to bring in more ramp components, volunteers, looking at also building some wooden ramps. So there's really some potential here, and this is really like seed money to get that all growing. So it's a great partnership. Heidi moved it. Do I have a second?
I'll second.
Okay. All in favor? Great.
Aye.
All right. Any questions about that? Thanks, Brenda. Thank you. If you want to go on to the health department, and we can look at Kathleen's report, or have her, we can get through the resolutions first, and then you can tell us the information you want to share. I'd like to group together HH 2, 3, 4, and 5, and you can discuss them all at once. We'll get a motion and a second when you've done reviewing them. Obviously, HH2 is a fill of a vacant position in WIC, 100% funded. HH4 or HH5 is also a vacancy, budgeted vacancy in WIC, nutrition assistant. 3 is entering into a contract, and this is not new, for the bike, pedestrian, wheel sports safety program with the Council on Physical Fitness. And then 4, once again, is additional funds coming into the county health department for vaccine response. I mean, we just accepted 85,000 last month, correct? I mean, or it was the month before?
Correct.
Yes. So we could get a motion in a second, and then we can, any questions about those, if you have any?
I motion to bundle
Okay,
HH 2, 3, 4, and 5.
okay, second? Okay. All right, any questions on those before we vote? Go ahead, Trish.
I was just wondering if you could elaborate on what the council, is it the Council on Physical Fitness?
Yes.
What is that?
So I love that. that this will be like my joyful, happy one to talk about. This is, so the Council on Physical Fitness was started by Joe Mushak, who's a retired physical education teacher. And even while he was still working, he's always been very of the mindset of make physical activities enjoyable, and people will carry that for a lifetime, right? And you can make it for people of all levels and abilities. And I'm going to just tell a little story because I think it illustrates it well. So when I first started working at the health department, it was a contractor, and this is fresh out of school. And I worked for the Healthy Heart Program. And Elaine remembers the Healthy Heart Program, or some of you do. So it's chronic disease prevention program. And I was part-time, and I would come in, and that's where I first met Joe. And the Council on Physical Fitness was getting started, but he helped operate the Healthy Heart Program. And that evolved into another chronic disease program for preschoolers. And then that evolved into some other school age ones. So Joe, because he had retired from the Auburn system, had in particular great relationships with the phys ed in the Auburn school districts. He connected with each of the Auburn elementary schools and started the clubs. And you might remember these, Max. Seward did circus night, and another school did rope jumping, and another one did some basketball dribbling and stuff like that. It's because he brought this curriculum and these activities into the school, and it became part of their ongoing curriculum. Cup stacking was another one that I thought, what a thing I've never heard of. Who does this? It was so great. Again, you didn't have to be the top runner. You had to be creative. You had to be able to stack. So this, and these have perpetuated, right?
He formed his own
He
DDA.
created this Council on Physical
Right,
Fitness so we could go after some more of these. And he's been involved in all of our chronic disease programs. This particular one sponsors Walk to School Day, Bike to School Day. He does bike rodeos. He does a lot of bicycle, scooters, that's why I say wheel sport, roller skates, and pedestrian safety. When we did the red crosswalks at one point downtown Auburn and other places, that was because of Joe and some of his involvement with us on these programs. So why I get excited about this, not only it's just a great program, right? And he's just done some wonderful, wonderful work, but it's been so ingrained, implemented, and made such a positive difference in how physical activity is provided, not just in Auburn, but throughout the counties. And all the schools is primarily where he works, in some community centers. And it's really neat. It's really cool and lasting effects. So it's been great.
Thank you for that. I didn't realize that. I think
Yeah.
he was my phys ed teacher in high school, and I remember playing tennis with him.
Yeah, right. And I laughed. I said, Joe, there was some stuff you do. I thought, oh, good luck with that. I'm like, yeah. And then sure enough, 15 years later, it's still going on. And that speaks to how long I've been around, but it's just how well thought out and exciting these are. And he's so enthusiastic about it. It's really cool. Yeah.
On the COVID response resolution that you're accepting, do you have to submit a work plan, or you're taking the money and you're going to see if you can obviously spend and claim it?
So here's the not so joyful part of my, right? So kind of, I don't know if Brenda's still on the phone. Human resources we are all desperate for them. You're all desperate for them. We got this money to provide marketing, to do COVID outreach and prevention, to do whatever it is we need to do for COVID response. Haven't even been able to get it. Can't even spend any time on that yet. We're still trying to get money out to the schools from the ELC grant that we got.
2 million.
We can bring on contact tracers, which is wonderful, but it's not yet enough to help with this stuff, right? We're getting through on the day-to-day, but not we got to get to this, right? There's the to-do list that doesn't get any shorter, but you really have to pick your priorities, what's immediate, right? And what do you have to get to immediately right now? It's going to be great if we can make use of it. I don't know if we will get around to being able to make use of it all. We do need to do a work plan. We have not done one yet. We got to get the school-based one done first, and then we'll look at this one. So, at some point,
Well, it's a matter of just because you put money to it doesn't mean you
Yeah.
can figure it out.
Human resources, and when Brenda was talking about the aides, I mean, that's not just for the program she operates, as you guys all know. Every single one of us is dealing with this, with aging family members and caring for them. It's human resources. Can't say enough about them. So within the health department, I spoke a little bit in the report that I gave. We're really just trying to prioritize what has to be done, because as I've mentioned before, the stall or the pause on different programs when COVID first emanated no longer exists. And so not only do we have mandatory program work that needs to be done, and we're prioritizing them, and our state oversight with state health certainly is very understanding, because they're experiencing the very same issues that we are. We also are responding to and feeling the impact of the vaccination mandate that impacted the health department, because we're at Article 28, Diagnostic and Treatment Center, and Article 36, Licensed Home Care Agency. So all of our staff need to be vaccinated. And we'll know next week whether we have met that goal.
What is your date? October?
So October 7th,
Right?
was the date that people had to be vaccinated. And there's an agreement between the union and the county to give a period of time after that for people to come into compliance. And again, going back to human resources, right? There is not an overabundance of staff within the health department, and everybody has been redirected and continues to be things at certain times to respond to the most immediate needs first, and COVID also, so it's frustrating at times. We get permission to fill a job, but you can't find a candidate who wants to work on it, even with the civil service list. Or you get someone who starts a job and they say, wow, I thought it would be this, and it is, but it's even more, and I don't want this, and they leave. You can say it's money, and that's something, and we've got money to a certain, right, within the confines of civil service. But it's finding people who want to try something new and stick with it. And then it's retaining the people that we have. And we've got great people in the health department. We need to keep them. We need to keep them. We need to try and, really think, because this is really, I guess, more of a budget discussion. We'll talk more about this, but I don't think of myself as of a certain age, because I'm not yet, but I work with people who they have options, right? They have options, whether they stay with us or they look for something else, because of whether it's retirement or just they have options because of their circumstances in their life. And I so desperately want people to stay where they're at for at least a few more years, right? So that we get some succession planning engaged and in place. And that's always what we're looking for also, as we try to fill roles and shuffle things around. But human resources. So yeah, the report kind of speaks for itself. We're doing all sorts of things. We spoke a little bit even about the need for testing. And EMO has been willing, but has limitations on their staff availability. East Hill is willing, but has some limitations on their availability. The hospital has just been saying anything you can do to help with testing, to take the press off the urgent care, the emergency room. Nobody should go to the emergency room for a test unless they're very sick and need emergent care. But people do show up there. Sure. And urgent and pediatric providers, other primary care providers. Where we see this impact the most right now is with our schools, because, and this is, it's a hard time to be a school administrator and teacher and school nurse and all of that, because of because of COVID, and we're all wanting to keep our children in school. So on the health department side, we're prioritizing, when we get test results, the children and their contacts, and then we get to the adults, and that's all fine. But if you have a child who presents at school and has the sniffles, could be allergies, could be COVID, could be something else. They're not supposed to stay in school, and the schools are doing their best, right, as far as screening. I know they're all working on it. That child needs to see their healthcare provider and be assessed, or stay out of school for 10 days, or get a COVID test along with something, there's all sorts of this, that, or the other. Okay, so if you're fortunate enough to have your child you have a pediatrician, great, call them up, the office says, yep, get them in, we can test them, we can do whatever. The test goes out for analysis. It's taking about 4 days to get the results back. So your child has lost a week of school right there. And then you get the results. And then if it's positive, now you go back to quarantine the classmates who might need it or not. They lose a few days of school, but not as many because we didn't get the results till late. And then it's not ideal right now. So we really need to try and find a manner to get symptomatic testing. And it's not something that the health department can take on and perform directly. We might be able to do 1 or 2, but we need other people to be able to perform that, and the supplies to do it, and the labs to analyze it.
So is it unrealistic to think of a model like the Cayuga Community College model, where they use pool testing weekly, bi-weekly, depending on your vaccination status? The results come back the next day. And use that model in the schools, because then, when a result comes back from a pool that there's someone in that pool positive, they just retest every sample and they find out the positive sample. And again, it's in a 24-hour period. There's not like a 4-day wait for one child. It's a whole population. And they rotate it over a week. It's very organized. And you said there's 1 million to roll out to the schools?
Yep.
Is that a possible model?
It is. And in fact, Moravia District is going to be trialing that model very shortly. They had a training last week. The very same organization that does the college. So they're going to try the pool testing because there is a mandate that staff who are unvaccinated and random willing students get tested also. What the schools are doing is supposed to be for asymptomatic.
That's surveillance.
That's a surveillance screening. But we are definitely looking at, can we do this for symptomatic? It's not the ideal for a symptomatic situation
Right.
because you're expecting to get hits, right? And so you have to be suited up but you have to be suited up for the asymptomatic also.
Yeah, they're suited up at the college.
Yeah. So that actually is one thing that we're looking at further. And I will say East Hill is trying to put something together for asymptomatic testing, which is great and it's particularly great for, I think my kid was exposed, I want to make sure, or I think I was exposed, I want to make sure. It's a chance, but that is absolutely one of the venues that we need to pursue further. We're going to sample it and see if we can do this for, it's not surveillance, it's diagnostic testing
Right.
on that one.
Let's get through your resolutions first. HH 2, 3, 4, and 5. Hey, did you make a motion for those?
Yeah, we've moved it.
Okay,
If discussions are finished, I think we're ready to vote.
second?
Yeah.
All right, all in favor?
Aye.
Okay.
I didn't realize you hadn't voted. So I've done a lot of my talk. I don't know if there's any particular questions to the the notes that I put in for the report.
One more question then about the Moravia School District. Was there a particular dynamic that got them thinking about it? Is it because there was an innovative or courageous administrator or boards? School boards have a lot to say about everything within a school. A school board that was more supportive, that made it a more possible kind of test site for pool diagnostic testing. Or, because in that case, then we would see that as, well, that's an isolated, interesting case because there was a charismatic or caring and innovative administrator with a supportive board. You're not going to be able to replicate that around school districts then. Can you describe what happened at Moravia to make it happen?
Well, I would say, yes, I think there really is a very conscientious superintendent, and I'm not knocking any of the other superintendents. All the school districts are doing some form of surveillance testing. So the superintendents had a choice of how they want to go about doing that. Some of them are working collaboratively with BOCES to facilitate their testing. And BOCES is doing the by next 15-minute antigen card test. The districts could choose. I think Moravia wanted to try this because I think their superintendent was aware of different possibilities, right? And as they're all paying attention. Some of the districts who may have chosen not to pursue this may have done so because a lot of them started doing Binax testing last year. And so had staff who were trained how to do it. And depending on what your sample population is, it's not terribly difficult to perform that and enter the data necessary. Moravia did some Binax because the pool testing wasn't up yet, but they'll be starting, I don't know their start date, but pretty soon they'll be starting it and we'll see how it goes. And I think if they have success, there might be others who might find that that'll be an easier venue or manner for them to do it.
Thank you for the insights, the clarification, the background.
Yeah, it's great. I will say it's, and it's not just about, it's everywhere, right? It's not just about schools, but I am most sympathetic to the challenges that our schools are facing since the start of the school year right now. All right, thank you. Let's move on to human services. We'll do the resolutions, actually. They're all appear to be requests to fill budgeted vacancies. H6 is a caseworker. 7 is a human services examiner in daycare. 8 is a senior caseworker. 9 is a part-time transportation aide. My understanding, all of this is in the budget, and these are requests to fill.
Nightingale, I moved to bundle, HH 6, 7, 8, and 9.
Okay, second. All right. All in favor? All right, great. Very. I don't see, I know Christine's on vacation, I think, or not available, but if there's anything you want to talk about in DSS, if not, we can move right to mental health.
Yeah, we just going, yeah, I'd like to
Okay.
talk about some DSS stuff and some
Okay.
also. Can you guys hear me with the mask on over there?
What's that?
Could you you can't hear me with the mask on then.
You can take it out. I'm
Yeah,
fine
right
with it
at the
off.
podium.
That was
I'm
the
personally fine.
question. All right, good.
That was the answer, right?
Actually, Marcus Welby, when I was a kid. I want to run down some numbers for you guys, some stuff that's happening in both departments that I think is good for you to know. I want to talk about that in the context of those proposals for the American Rescue Act. So I think, like, the health department, has been very affected by all of this and working tremendously hard. You guys are doing a great job. Too bad that we can't see the end. There's been some significant impacts in social services and mental health department related to this as well too, because the pressures that we're all under affect all kinds of people in different kind of ways, and we handle we take care of a lot of very vulnerable people.
So we have 90 homeless households now, which is about 35 more than we typically have at this time of year. We're going into code blue, which means we have to house everybody, regardless of whether they're sanctioned or not, when it's 32 degrees or below with the wind chill, which is like November 1st to March 15th, generally speaking. We're not going to have enough motel rooms. There's been a lot of challenges in the motels. I talked about those before. And OTDA we had a call yesterday with OTDA and the commissioners. They put out some onerous hotel regulations that would require departments to deliver meals to people and require different things for the motel owners to do, which is going to make motel owners say, I'm not doing this, because every year they don't want to do it. We have to really work hard to keep them engaged. It's $2,800 a month to house somebody in a motel versus about $1,100 in a shelter. So we're going to spend, again, probably $1.5 million on homeless services in 2021. Another thing that's been a particular issue for us is when Arise got out of the rep payee business, they wouldn't work with us to transfer that book of business to a local agency, and they pushed that out to an affiliate of Helio out in Syracuse, which is problematic for the people that have rep payee issues because they don't have cars, and that's where their rep payee is, and that's been a challenge. But now they're not taking any new people, so Adult Protective Services is getting an awful lot of rep payee referrals. Manage people's money. We manage people's money for a number of reasons, right? They can't manage their own. We pay their rent. We do all that sort of stuff. It's a lot of work, and it's sort of busy work, which sort of takes away from like some of the cases that we're seeing in Adult Protective are, the isolation and the not having the support that you typically have. You heard about home health care aides. That I don't think there's words that really can explain what that problem is. And how significant it is and how real it is and how impactful it is for people. We have over 90 kids in foster care today. We were at 70 about a year ago. Driving that is an incredible amount of child protective services. They've had 43 calls this month alone since October. And in CPS, you get all different kind of calls. Seriousness of the calls are a little concerning. We filed 11 petitions last week. The calls this before sex abuse cases. Kids ingesting drugs on accident. The staff is down. I mean, you have people who are out. The COVID thing affects us there too. You'll have a couple of people in quarantine or isolation, and you got the other people came into contact with people going on vacation. There's some folks with 30 cases. You're supposed to have 15. So this is a concern in the department as well. Over at mental health, since September 1st, we've had 147 crisis walk-ins. A crisis walk-in gets dropped out by the police, by a school district, by anybody. And they're different than the 262 walk-ins that we had, which were people just coming in to get services. 39 hospital discharges. That's 409 new cases that we had to see, that we saw that day. That's 15 a day. That's a lot of work because everybody's pretty much past full where they should be. I've talked about the prescribers and their caseloads. We're seeing a lot of adults with developmental disabilities because the Article 16 in the county has a 6 to 8 month wait list. So none of those folks are getting treatment. So they're told to come to us. The other mental health clinic in town is experiencing significant psychiatry issues that I think are probably getting resolved a little bit, but we're getting a lot of business, and this is very concerning. We're also seeing more of the patients for medication-assisted treatment than the providers that are supposed to be seeing the patients for medication-assisted treatment, because we're going to be a low threshold buprenorphine provider because we're doing harm reduction trying to save people's lives. On the healing community side, going back to that buprenorphine stuff, 219 overdoses this year. That's more than we had all of last year, and it's only October 11th. That's 24 a month. It's pretty frightening. 14 fatal overdoses at 21 last year. I don't know, where we're going to end up. I know that there was Elaine was in the meeting today. There's a lot of, there's a lot of effort at a lot of bystander sort of, savings, people saving lives because they've gotten Narcan, distributing an awful lot of Narcan, doing all that sort of, that money, the money for all of that and for some of the staffing is gonna go away in June. And I don't think the problem goes away. So I think that's something that we should be concerned about. I don't see any of this stuff like getting any better, because it seems like, and you probably all feel the same way. It's like in some regards, it's like there's a lot of pressure boiling in underneath everybody. And if you don't have means to cope, or you were barely coping before, and now pulls you into that where you can't cope anymore and you need some resources and stuff like that. So this is serious stuff. We put in some proposals in June to sort of, address this. So I know Trish put this meeting together, so I'm just gonna go through it now, pick out a couple of different parts and talk about some stuff that's going on. I put this meeting together with what's that company that's the developers from?
Housing Vision.
Yeah, Housing Vision. So these guys, they know what they're doing. Like they did all of Orchard Street and they did Westlake Ave, and they do stuff all over in a bunch of different counties. And they did a shelter over in Syracuse. So they've looked at, so you all know where the shelter is on Grand Avenue, right? So the city says that's okay, that can be a homeless shelter, it meets the zoning requirements. The Chapel House Board met and said that they would go down the path of figuring out, making it into a shelter that would meet the needs of the county. So you're looking at a dormitory style, 2-story shelter, single men, single women, with a capacity of about, I don't know, 75, 65, so you could roll the other shelters into it, so you get economy of scale, you know what I mean? So that company, everything's all set, like the city says okay, and the Chapel House Board says okay. So now they're gonna need some money to do the groundwork, the site stuff, the zoning stuff, the variance stuff, the plans, the speccing it out, how much it's gonna cost and all of that. There's a lot of money out there to fund shelters, but you have to have that part done first. Because, OTDA has HHAP money, they have a bunch of other money as well too, and they're really good about giving it out. But you have to have something to go pitch to them. You can't go say, we want to build a shelter, can we have, this, because they're gonna say, and then you want OTDA to look at the plans, make sure they say, that they weigh in on it and say, this is something that we would, because they license them. This is something that we would license. Plus you want them working with you, you know what I mean, right? Because they know a lot of stuff too. And these guys got some experience. So that's floating out there. I don't think there's a number on that proposal. I think it was just put in as a sketch. He spitballed it at $500,000 to get started. Trish thought she heard another number, but there's a number out there that they can give us. So I think that would be.
Can and should.
No, I know.
Right,
He's
yeah.
Yeah. He asked me, I said there, last time we talked, it was before the meeting where you guys talked about, like it was the last ledge meeting when you talked about what was gonna happen with these proposals and all of that sort of stuff. And I said, give me a number. And he said that. So I mean, we need to put something to paper. There's no doubt about that.
And you're right, it's huge, Ray, that the city of Auburn is.
That hasn't happened before.
involved.
No, that hasn't
Yeah,
happened before.
Yes.
And there's only a couple of places, you can only have a shelter out on Grand Avenue or out on West Genesee Street. So those are the sites, and this is a site that's in a good spot.
Yep.
There's a bus stop there and all of that. We also put in a proposal to,
Crisis.
Hmm?
The daytime crisis.
well, for the foster care enhancement, I'm just going by through the department. So, Family First started on September 29th. We're actually doing our first QI evaluation to see if there's a kid eligible to be put in a residential treatment facility. So we really wanted to stipend the foster care families that stuck with us because we had that one disruption during all of COVID, which is like unbelievable because they were teaching kids, everybody was, it was hard, everybody being at home all the time, and they hung in there, So something for them, but also some money to help us recruit additional foster homes because we do need more. So that's kind of flowing out there as well. On the mental health side, we put together that proposal for the two mobile crisis teams. One that would be working with, both of them were partnerships with the mental health and DSS. One with child welfare, CPS and a therapist to go do some of this work. And also on the adult side, to go out and do that work as well. And I think we put a placeholder, and we met with, I think we talked, Mona and I talked with you and Aileen about sustainability for
The investment of maybe.
the healing money. Yeah, but we just, but so there's a proposal putting together. So I guess I'm saying all of this because one, it's important, right? For you to see sort of what's happening out there, because this is pretty serious stuff. And so I know that you guys are in caucus talking about these things. Just impress upon you the need for urgency. Move this money as quick as possible. Let us get going on this. I was hopeful that those teams would be open, would be ready to go at the beginning of the school year. That didn't happen. Just like Kathleen was talking about the stuff that's happening in the school districts related to the nuttiness of who walked by who and sneezed, and this kid's got to stay home and they got to get tested. They're also having an awful lot of aggressive stuff happening on social media. There's an awful lot of suicidal ideation. There's a lot of kids in crisis. There's no hospital access. There's a lot of kids in the community that are really pretty shaky. And we'd like to be able to sort of wrap our arms around that a little bit. So I don't, the fact that we can't come into caucus to talk about this sort of stuff, to put some context to it, it would be nice if we could do that. I don't think that's going to happen because it never has. But if you could say, how can we move forward in a way that has urgency and could expedite some decisions? You're still like $2 million, I think, short in that bucket for COVID impacted sort of stuff. So it isn't a question of the funding. It's really about the decision and a process for how to move forward to get going on. I think it would be really helpful, to the departments. It'd be really helpful to the community. And there's, you just get tired of people dying. It's just, it wears on the staff and families and everybody. So that was it.
And this is just kind of off the side. The work of at some point, do you envision that another Article 31 will be needed in this community because the need is so great and you can only stretch current agencies?
I think that
we talked at one point, Arise was thinking of doing something with the Rep P and that kind of, it is a.
I think that if all the clinics behave the way that they should in terms of, opening the doors, still challenges with people getting admitted. It's more about, so I just have a lot of experience in this. I've been doing it for a very long time. I was realized today that I've been coming up here 20 years now, up to this room to talk to the legislature about stuff, started in '92 at Cayuga Counseling Services with some of the juvenile justice stuff that we did. I think that most clinics don't, it's a culture thing in the sense that, it's really nice to work with a worried well, you know what I mean? And it's not really nice to work with hospital discharges and schizoaffective people and all of that. But I think people want services when they want them. So I think that it would be better if they all sort of became an open access clinic, which would drive the revenue that they would need to hire the people that they need to do the work. So it's really hard if you bring, so it's always this thing, right? It's like, if you bring in another provider to do something, is there enough business to go around, and does it jeopardize all of the providers? So this is the thing that DCSs have to think about all the time. And also too, the character and competence of an organization. I wasn't going to let Arise come in and open up a clinic when they wouldn't talk to us about moving the Rep KE people from an agency that we want to do. Why would I have a partner like that won't talk to us? All right, we don't need that. And I also know how these clinics function in other counties. So I think that, I just think that there's other ways to skin the cat too. So I think that if we can be mobile, when we look at so we evaluate this stuff and we look at it, right? We do this all the time. We're looking at the numbers and we're looking at strategies and stuff like that. I think that a lot of this stuff can be handled in the community before they have to come to the clinic to get the service. So we can bring the service to them in the community and we can resolve the issue, and we can use some of the contract stuff that we have. Because I don't think it's really, especially with kids, I don't think it's a really good idea to medicalize behaviors and then medicate the behaviors without looking at what's the driving forces that are happening at home. Because if the driving forces at home
Get
don't
better.
change. You just give the kid more medication to control their behavior, and then you got another problem. So I think that we have to watch it and see kind of what happens, but those would be, that would take some of the pressure off of that in the course of a day, having to fit in, 14, 18 people when a therapist could. I mean, they made me move the bathrooms, converted a men's room because it was less steps for them to go to that bathroom. This was their idea, to go to that bathroom than it was to go to the other bathroom so that they could get people out of the waiting room quicker than making them wait that extra 45 seconds. I mean, that's kind of how they are. Free, got like flowers in the air, and some plastic flowers, but you've probably seen it even in the building lot. So some urgency and some direction for department heads on how to really sew that up and move the money and start building these resources and this capacity to do the work. And I'll get a number, or I don't know, Trish, you want to talk to them and get a number? You want me to do that?
I want to follow up and
Okay.
maybe see if we can even convene a little bit.
Okay.
Have another meeting to see
All
what
right.
the plans are. So the shelter is one piece of that.
It's only one piece. Yeah,
Yeah.
the city's looking at rehabilitating neighborhoods like they did on Orchard
Standard
Street.
sites.
They got some other spots that they're, it's a really, and they can do it too, like they've done it before. They're really, it's nice to work with someone like that who gets it.
Yeah.
And can make it happen and all of that sort of stuff. But that's like 2 years away. Even if everything worked all right, it's a couple, 3 years away from building it. And we're gonna be stuck in this motel business for a while, but I'm worried about having to send people out of county this year. I think people are traveling
Services?
for homeless to house them.
Okay.
And people are traveling again. I think last year it wasn't such a big thing because people weren't traveling so much. Like the motels were really sort of empty, and we're like, thank you very much, right, for putting people in there, because the Inn of the Finger Lakes was going to close the day that we called them and said, would you be interested in doing this? And they said they would be. But now you see cars parked in the motels. You see
They have
people
another book of business.
They got another book of business, and it's interesting. Like, I think when people talk about, how we have to increase tourism and all that, which is true, but there's a lot of tourism that really happens in Cayuga County, because we can tell when the motel says we're full, we can't take anybody. And it's just interesting to me that happens. So, and I just want to correct something on the report, where I talked about the part-time DCS. That's an error. It's full-time DCS. The splitting the position, like if you look at the local law, the third part of it, I think that's a mistake. I'll talk about that at the ledge meeting at the public hearing. It's still a model that nobody else uses. It's redundant, and I would argue that I've been a fairly successful director of community services for the county, and I think that is in direct relationship to being able to make the clinic do what it needs to do, because those people work for me. I'll tell you truthfully, no one would take these developmentally disabled adults and treat them in an Article 31 unless somebody made them do it. And you can't make them do it, because it's really challenging to work with. We're cognitive based, so you have to talk. People talk, figure out what's going on. Article 16s are behavioral based, so they're different. So when you're prescribing medications for people who don't understand quite the words that you use, or don't have the words themselves to communicate how you feel, what's this doing inside of you, and you're adjusting medication, it's a dicey proposition. So I can make that clinic do stuff because those people work for me. If I couldn't make that clinic do stuff, there'd be families without services for kids that they want to keep at home. Adult children, some of these families are heroic in what they do to keep their adult children at home. And so anyways, that's my story. I'm sticking to it.
Right.
So do you believe that without your leadership, the culture that you created at the mental health for that to be an important part of the work falls away, that you have to press them to do that work? I mean, you can be honest.
I am. I'm thinking about how to answer it. I'm honest.
Like, you're gonna be stepping away, so.
I think that there's a core group of people there that, like, so when I got there, so it's not me, like, it's like, I think like So I get the leadership thing, you know, I think that's important and all of that, but you also have to have people who are willing to do the work. Culture change is really, really challenging. I think the culture is completely the way that it is. It's like people walking in, we're seeing them, cops drop people up, we see them, someone's in the waiting room, they take their clothes off, okay, let's get them a robe. Like, it's not like they're freaking out about it. I don't think that changes. I think the danger, the risk is, you know, it still needs attention, right? It's still gonna need an advocate. It's still gonna need someone who helps them figure out what the right thing to do is in situations, because I think that's important for people to know that you're gonna help them get an answer, and that they can feel like it's an ethical answer, and they can do it. I think that's important. I think the work in the community is the greater risk. There's a bunch of different initiatives, there's a bunch of things that are going on that really need attention all the time, because, you know, like I mean, you know, I took a lot of heat around, you know, how agencies feel about, you know, whatever they feel. But it's like the job is to make the agencies do their jobs as well too, because if they don't do their jobs, work doesn't get done, and it falls to county mental health, and it falls to the Department of Social Service. So somebody who can, you know, the healing community stuff, that kind of attention that stuff needs. You know, the work with mobile crisis, the work with substance abuse providers, trying to get them to become more, you know, accessible to patients and not kick them out so much, and push a housing first policy so that the providers that are providing these services, both on OMH and WASA side, aren't creating more new homeless people with greater problems. I think there's where the greater risk is, that leadership in the community. Not everybody likes it. I mean, not everybody likes being held accountable and being, you know, gently and lovingly convinced to do the right thing. So that's kind of, I mean, does that help?
Yes, it helps. A follow-up.
Sure.
So because the local laws written gives us flexibility, we don't know what will happen down the road
But
when
why
it
put
comes
it
to
in?
hiring it.
I mean, why would we be the leaders in this area where no one else is there?
But let's say the scenario is the hiring scenario turns out to be a full-time mental health director and a full-time separate person who's the director of community services. Why would not a strong leader with the culture that you've developed and someone who can step in and maintain that culture and maintain the vigilance around that culture, why would that conflict with a separate director of community services?
I'm not sure I'm following what you're asking. So I think that you're talking, so let's see if I'm getting this right. So there's the way that it is now, and kind of in every other county that runs a clinic, is the DCS oversees the clinic and the mental health department.
Right.
That's traditional, and that's sort of the way that it is, and that works, and everybody sort of is happy with that, more or less. The idea of having somebody run the department, and, you know, a full-time person running department and a full-time DCS. So here's why. So first off, it's more expensive because it's another person. Now the DCS, who has to get the psychiatrist to do the 730s or do the AOTs, or get the clinic to take the developmentally disabled patients, or get the clinic to start doing buprenorphine, or get the clinic or get the therapist to go mobile, get people to go do things that they really don't want to do. Now that the DCS has to go to the person who's running county mental health and say, can you help me? And I think that's a problem, because a lot of times the answer is, we don't do that. So and even if they say we don't do that twice out of 10 times, that's the problem. So I think that the effectiveness that I've been able to sort of have is because, so sure, the culture has to sort of mirror like the vision, which is we need to be assertive in the community with patients. We need to meet the need. The thing that I would always say is, we're not just responsible for the people who are in the building, the patients, we're responsible for the entire community out there. So that's what they've sort of absorbed over the years is, oh, so this person that's at home with the tinfoil in their house, who won't come in for an appointment, we should really work harder to get them in, instead of saying, no, where everybody else says, well, they should come in. So you really, if you want that, I mean, this is my opinion based on, you know, the 10 years of working here, is that we would never have the system of care that we have now if I couldn't
Direct it.
exactly, because that's the statutory, requirements at that job, that's the powers of that job. And powers mean nothing if you have no one to help you realize that. Like you have, right? Kathleen has powers. If she didn't have the staff, it's sort of similar. You'd have a public health director and a director of the health department. That doesn't really make any sense because she needs to go to her people and say, we need to do this stuff. I'm not working Saturdays or Sundays, you know, we're not gonna make my people work, you know, it's like, it's really doesn't, to me, it doesn't make sense. I really do want to impress that on people because that's really important. And also too, that local law language has caused two people who were going to apply for the job that would have been really good not to them. Because it's like, what's going on over there? That's so uncertain. That doesn't make any sense. I don't understand. I'm staying where I am. So there's the practical application of what happens when we don't send clear messages with what we're looking for. Because I've been recruiting people to apply for this job because it's really important to me personally and professionally. I have great affection for those people. Just like I said, great affection for the people in the Department of Social Services. I want them to have the leadership and the attention that they deserve. That helps them realize the goals that they saw for themselves and do the work that's really important to them. So why that doesn't make any sense, this doesn't make any sense for the same reason. It's me talking, everybody, people can disagree.
And you know, the flexibility of the language, I don't believe, and you and I talked about this, I don't believe there's an appetite to go ahead and separate those two positions. The expense is clearly one. I don't see it. Heidi was on the committee as well. I don't see that being.
It's not the direction or the
And
appetite.
even if you take the flexibility out, if the county wanted to do that, you put another local law. And
Pass
do
a
it
local law,
differently.
they're not
I
that
mean,
hard.
Right, you do. So I mean, it can be either way.
It's just not done though, like, it just isn't done in
Well, and
counties this size at all.
that's part of the investigation we did, that if no other county, small rural county who runs a county mental health clinic has separated those two roles, I guess why would we?
And so the other thing, in fairness, when we talk about this way, we're not talking about what's the plan for hiring someone. We're not talking about getting somebody in there on time anymore. It's taken a lot of time and energy and attention away from the recruiting and the hiring. So you're gonna end, I'm telling you, you're gonna end up with an interim now, which is awful. There's no way you're gonna get anybody in there in time. It's impossible. You can't hire.
Well, I mean, at this point, that's why we had the initial conversation about trying to get the Community Services Board to move on this now. We don't have to wait till the end of October to even put the ad out. I don't think we do, and I don't think we should.
Well, there should be some, I guess like again, like,
And
it's, I mean, you know what I mean? Like, it's sort of decentralized in a way, right? Like the committees hear this stuff and it has to happen. So how does that work? I don't know. So you have to, that's what I'm saying. It's like some urgency and decisions on these issues would be really, really helpful.
Right. And there is urgency from the Community Services Board's perspective to try to get at least the advertisement out to see what, you know.
And they're
what
not
interest-
bound to this local law. They are freestanding community service board. They're not bound to this local law. They can begin to recruit right now.
They can. The county's obligation would be to appropriate. And, you know, again, if we wanted to, I guess.
Yeah, but you have to say it to them. You know, it's a partnership really between the county and the Community Services Board.
And the DCS does have some leverage in the community based on the allocation of state aid too, right?
It's not that much, Jim.
It's like 1.4 million only, or
The state aid that goes out, the state aid that goes out to agencies is probably, you know, that's discretionary, probably, you know, because so Unity House gets so some of the state aid is not discretionary, like it goes for the housing programs. That's where the chunk of it goes. So Unity House gets a bunch for the mental health housing and also for the halfway house. So a lot of that is accounted for. The stuff that goes for the state aid that goes for, like, you know, AOT and children's SPOA and adult SPOA and all that stuff.
you get a lot because you provide the
That's in the
service.
clinic because that's where those services are. So discretionary, there's probably around, I don't know, probably $250,000, $300,000 in discretionary contracts, which isn't really a lot. So there's not really much like the typical things that you would do, or I think we've been able to use that state aid with the Department of Social Services money to create more opportunity for services. And we have built a really robust system that way, really from the blended funding has more to do with that than it does with the state aid blending with it gives us a lot of flexibility, so we don't have to, doesn't matter which door a kid comes in, they're gonna get everything that is available in the community to be offered to them. Not, you're a mental health kid, you're a social child welfare kid, all that sort of stuff, but not a lot of discretionary money to spend. Most of it's accounted for. And we RFP it when it comes up.
Well, we have the public hearing in 2 weeks and then the vote.
Yep.
And I think if the public hearing clarifies the fact that this is not an intent to separate mental health director and director of community services, perhaps these candidates you'll have in mind. I mean, you can interview for a job and say no. If you find out it's not what you're looking for, if it was some, shell game where we pull away and say, oh, no, we're really just looking for one piece for you. I don't understand why it would pull candidates away. I can interview for
Well, I think
something
what
at
they
any
say to
time
me
and
is, it's
pull
like,
out,
no one does this, why are you guys doing it?
because they're not understanding the language of the local law.
They're just
Okay.
understanding traditionally how it is, though, I guess, like,
Well, that's why the public hearing could provide clarity, I think. And I'm hopeful that it will. There's no intent to divide and conquer.
So HH10 is the amending the mental health 2021 budget to adjust some state aid allocations.
yeah, it's just there's a few dollars that change. So we bring those resolutions a couple, 3 times a year.
Because it's kind of a cleanup thing.
Yeah, the state aid letters, you start out in the beginning of the year, they say what you're gonna get, and then you can get a COLA sometime during the year, things change. So it just changes the numbers that are getting allocated to the agencies.
Is this something the Community Services Board looks at as well?
Not that, because that's just
That's
just
minor
housekeeping.
adjustments?
Yeah, that's
Okay.
just housekeeping. You can't do anything about
Okay,
it. You have to
Fine.
accept it and move the money along.
okay. Can I get a motion for HH10, amending the mental health budget to adjust the state aid?
Second,
All in favor? Okay. And then HH11 is, as Heidi said, is to adopt the local law, repeal law number 5, 2014, and separate the departments back and post the public hearing. Can I get a motion? Okay, second.
Didn't you do that last month?
Well, this I guess is to set the public hearing. I
Yeah.
guess. And that's back on the agenda again, so
Set the
yes.
date, yeah.
Okay.
Yep,
Thank you.
thank you.
Thank you.
It's dark so early now, man. It's weird.
Anything else? Which one?
County attorney.
Yeah, the county attorney one is to.
Did we already do that?
I just talked about it today, repealing local law, separating the departments and
Right.
having the public hearing. The public hearing, we did it last month, but this one
Right,
is the
okay.
public hearing.
Okay,
And it sounds like there might be some public to be heard.
okay.
Okay, all right. If there's no other business,
Move to adjourn.
okay, all right.